I appreciate and thank you very much for the invitation, kind invitation, to talk about a very important and controversial issues as well. Uh, this is a confrontation between the uh, surgical colleague and the medical oncology colleague. So uh, you take it in a spirit that you need to understand the depth of the subject. Only then you will be able to make a justice to the patient who are suffering from this disease. No disclosure. History is very important. Do you know how that patient was treated who are having metastatic renal cell carcinoma? There are no studies except the Bumpus, H.C. Jr. In 1928, he published a report of apparent disappearance of pulmonary metastasis in cases of hypernephroma following the nephrectomy. That was a game changer. Following that, everyone tried to remove the primary tumor with an expectation that the secondary will disappear. But it didn't most of the time. This is very interesting. And this continued for a long time, from 1980s to early 2020. In 1980, the interferon alpha was introduced, and it was continued up to 2020. And from 2020, the ICI or the immune checkpoint inhibitor and IO based combination therapies have been emerged as a first line therapies for the metastatic RCC. And cytoreductive nephrectomy became more controversial, which was the primary treatment, became more controversial in 2020s, in 2000. And now what is the station now, where we are here? If you look into this picture, after 1982, there has been a lot of improvement. You can see the different molecules have been invented and they are taking places. Say, for example, nephrectomy immunotherapy was quite popular in 2001. I am sorry. Sorafenib was introduced in 2005. Then pazopanib was introduced in 2009. Then the era of IO has been entered. We have entered into the IO in 2011 or 2015, where nivolumab and the other product all have arrived until 2018. We have got quite a number of effective molecule in the IO setting. Then we need to know something about the treatment molecules which are used for the treatment. For example, sunitinib or axitinib, they are the inhibits the cellular signaling by target multiple receptor tyrosine kinase inhibitors. So these platelet derived factor actually causes the vascular endothelial growth factor inhibition, which play a major role in both tumor angiogenesis and the proliferation. Why the combination is required? Why only TKI is not been able to solve the problem? Although the combination of immune checkpoint inhibitor is the first line treatment in the MRCC, then it is mostly caused by the resistance of the tumor regrowth. So after some time, the tumor again grows. Therefore, an optimal second line therapy is necessary. Such therapy is typically comprises of vascular endothelial growth factor, TKI. What is IO? This immune inhibitors is something like this. When the tumor is presented as a single cell into the kidney, then obviously the macrophages and the T cell used to challenge it, that whether this is a foreign body, this is a foreign cell, this is a it should be destroyed. Then it liberates a PD-1 inhibitor. Then PD-1 inhibitor is saying that we belong to your native system of cell from the kidney and don't fight with us. So when we have understood it, then PD-1 inhibitor became a good treatment. So having this idea, this has been used in the treatment protocol. And you can see there has been progression-free survival as well as overall survival is much better. And when these two molecules are combined together, the treatment become overall survival become much more favorable. Having this in background, let us understand a study. A 62 years old man, he presented with a 1 week history of hematuria. Ultrasound and compound CT scan identify a 8 centimeter exophytic left anterior renal tumor and 3 small lung nodules. No bone or central nervous system was involved. His ECOG status was 1 and also the MSK-CC score was 1. This particular patient want to know that whether he can go for cytoreductive nephrectomy in this particular situation. What you will respond? What you will say? Anybody? If no, then we will try to find out the real answer at the end of the presentation. This highlights a common dilemma. Along with the clinical spectrum, this cytoreductive nephrectomy is inappropriate for this particular patient who is 41 years old and few metastases in the lungs. This cytoreductive nephrectomy will not make sense in a 80 years old man with competing risk and the bulky metastasis tumor burden. Most of our patients fall in the middle of this extreme. In our current scenario, the effective targeted therapies of the metastatic kidney cancer, how best we can manage about the patient with cytoreductive nephrectomy. Cytoreductive nephrectomy has been stepped down. We are not using in practice unless it is needed. But we cannot avoid it because it is very much important, because if a huge tumor is remaining in the kidney and it is producing a lot of local problems and also the systemic problems like hematuria, varicocele, the hypertension, etc. Unless the primary is removed, then possibly all these issues cannot be solved. However, the systemic therapy is also important. So some kind of combination and permutation was needed today when is needed. So having this background in mind, since the publication of BUMPS, no study have been done for the definitive treatment for the cytoreductive nephrectomy. The true benefit was found in 2001 with two studies. One is aortic and SWAG study that utilizes the alpha interferon and median survival of 11.1 month in the nephrectomy with interferon versus 1 month in the interferon alone in the SWAG study. Having said that, you can see the changes of the cytoreductive nephrectomy. Gradually it has been replaced by the systemic therapies. But to my opinion, the local therapy is also required. In some cases, when it is required, it should be done also. We will come to that. If you look into the localized and local-regional disease, the local treatment is required. The only surgery is required. If it is small one, T1, T2 can be best managed by the partial nephrectomy. If it is more than that, then you can do the radical nephrectomy. And if if it is advanced, in that case, you would have to take the cytoreduction and the sampling and then go for systemic therapies. Quite an important observation with the Carmina trial, which is sunitinib alone and sunitinib and cytoreductive nephrectomy was done in other hand. So both the hand, the patient was studied for quite a long time, and it was found that the patient who were on sunitinib was not inferior to the cytoreductive arm with sunitinib. So the comment was more or less, I think, when the tumor is small and the minimum secondaries, in that case lung mets are small, in that case cytoreductive nephrectomy can be done. But when the cytoreductive nephrectomy become difficult and also the tumor is bulky, at the same time is metastasis is bulky, in that case systemic therapy should be continued faster or given the preferences. So the importance of cytoreductive nephrectomy is there, and over the cytoreductive nephrectomy the systemic therapy has taken its place. So combining, the Carmina trial was found to be found that the sunitinib monotherapy was not inferior to sunitinib plus upfront cytoreductive nephrectomy in terms of overall survival. Moreover, the Certime trial that was found to be detected in cytoreductive nephrectomy was as safe as upfront cytoreductive nephrectomy. However, both trials have got some limitation. Rationale of cytoreductive nephrectomy is there. Eliminates the immunological sink. It prevents the secretion of the pro-tumoral cytokines and limits the development of new biological clones. All these actually actually addressed by the cytoreductive nephrectomy. This cannot be underestimated. Cytoreductive nephrectomy in the era of targeted therapies, you can see that it is not been used as a primary treatment, but as a secondary treatment it can be done. Can I have 1 minute or 2 minutes? 2 minutes, okay, thank you. New trial in progress, because this Carmina trial as well as Certime trial, they are not giving a good, very good prognosis. At best 10 months or 15 months survival is seen. So better trial is required. Keynote 6-9 with pembrolizumab and the sunitinib is done. Clear 19 everolimus and the pembrolizumab, and Contact 03 atezolizumab and the close cyclobin. We are not using it, that's why I am not very much familiar with it, but these trials are in progress. So combination therapy, you can see that generally they are combining therapies. If it is a small bulky, in that case simple combination is good enough, but in cases of bulky disease we are having this proposition has been given by ESMO. So for the time constraint, I would like to close here that multidisciplinary team evaluation, IMDC criteria and the metastatic burden, all these things will be done by multidisciplinary team. And favorable risk factor, they can go for upfront cystectomy, but poor risk factor, poor risk IMDC, they should go for upfront systemic therapies. So having said that, I would like to tell you that despite of substantial recent progress in the treatment of the metastatic kidney cancer, most patients cannot be cured. The result of the Carmina indicate that the cytoreductive nephrectomy continue to make sense of select patient. Rather than discarding the nephrectomy, we will need to continue to refine the treatment of patient selection as a new data on systemic treatment will emerge. So with this point, I am trying to impress your attention to the case we have presented, the treatment you understand now. Very good. Simply, you can understand the patient presented here. He can go for definitive therapy with cytoreductive nephrectomy, and also for the metastatic lung lesion, he can go for systemic therapies. Even systemic therapies followed by cytoreductive nephrectomy is also an important goal of treatment can be accepted. Thank you very much.